I'm Paul Connor. I have been working in the field of FASD since the mid-90s. Started my postdoctoral fellowship at the University of Washington and then continued there until about 2000.
Is it on? Yeah, it's on.
Green's on.
Yeah, okay.
Until I was at the University of Washington until about 2007, 2008, and then I went into private practice. A lot of my focus has been on adults with FASD. I don't do assessments of kiddies. I just do adults. And in my private practice, it's focusing on diagnosis. Part of my work with the university, and then kind of continuing even after I left faculty or paid faculty position there, was I worked with Joanne, and she was getting trained and working with a program called the Parent-Child Assistance Program, PCAP, and they had a number of people who were concerned about who might have FASD. The moms might have FASD, so I was working with Joanne to train her on doing these assessments for these people with FASD, and we'll meet or people in the PCAP program. So we'll meet one of those people a little bit later on. You've already heard everything that you need to know about FASD. The panel just told you everything. All I'm here for is as a supporting character, because I've been involved in the research, and our research was actually directed by parents and families with lived experience of FASD, because that is the most important thing. We need to be able to provide the information that they need in order to go to service providers and institutions to get the services that they need. I oftentimes will talk to my patients, and when I've done the testing, it's like, nothing is probably going to be surprising to you. You've known all these things all this time. I'm just giving you the numbers to back this up, okay? So we'll talk a little bit about kind of FASD in general. I don't know how many people have been heavily involved in the field. And then we'll talk a little bit more about kind of the diagnostic process, different types of red flags or screenings that can be done to try and pick up on people with FASD. I always want to start off with a quick questionnaire. So here are some true or false questions. And I want a show of hands first for how many people think that it's true. Then I'll ask how many people think that it's false. So most patients with FASD are mentally retarded. How many think that's true? When I started in '95, most people put their hands up. How many think it's false? Okay, very good. FAS, fetal alcohol syndrome, so all the facial features of FAS is more severe than partial fetal alcohol syndrome or people that don't have the physical features. True? False? Correct. We'll see that as we go along throughout in all of the research that's been done. We really have not found a significant difference between people with the physical features and people without the physical features. Children grow out of FASD. Well, forget this. We already heard they don't. FASD children can't learn from their mistakes. That's interesting. We heard about cause and effect. How many think that that's true, that they can't learn from their mistakes? Okay, you guys are smart. That's correct. It is false. FAS means that children are born drunk. Well, they may be under the influence of alcohol when they're born if mom was drinking right up until labor, yes, but no, they're not born drunk. It doesn't mean that they are absolutely going to be alcoholics. And FAS, they can't be treated. That's actually something that, for a long time, we were worried that that might be the case, that we just couldn't find treatments that would help. And the research is still, unfortunately, slim, but it's getting better. So I'm going to talk about the term FASD, fetal alcohol spectrum disorders, and that is not a diagnosis. It is just a term. It's an umbrella term that takes into account all the different actual diagnoses, such as fetal alcohol syndrome, individuals with facial features, short stature, people with partial fetal alcohol syndrome, some of the physical features, but not all of them, and people with alcohol-related neurodevelopmental disorder, ARND. They don't have any of the physical features. It's the hidden condition. There's also some other diagnoses, more prominently nowadays, NDPAE, neurodevelopmental disorder associated with prenatal alcohol exposure. That is a diagnosis in the DSM-5. That's a psychological Bible for us, where we have all of our diagnoses, major depression, anxiety disorders. Now FASD is in that same book. These diagnoses up here, FAS, partial FAS, and ARD, they're really medical diagnoses because they are based on the presence or absence of physical features. Speaking of physical features, there are three main facial features that are used to diagnose fetal alcohol syndrome. The short palpebral fissures or small eyes. Sometimes it looks like their eyes are really wide set, hypertelorism, which oftentimes does occur, but when you actually measure the eyes tend to be small. Indistinct philtrum, so those ridges between your upper nose and your lower and your lip, your nose and your upper lip, sorry. Those ridges tend to be smooth with people with full FAS. And they tend to have a very thin upper lip. Any one of these features is totally normal. You can have it for any number of reasons. When you get all three of them together, we don't know of any other cause for that than alcohol, prenatal alcohol exposure. There's a lot of other associated features that we look for: ear anomalies, odd ridges inside the ears, epicanthal folds, the skin flap in the inner corner of the eyes. Perfectly, absolutely a normal part of development for certain ethnicities, but we tend to see it in people who are not of Asian, Native American descents. In Caucasians, we tend to see it more frequently. Small chins, a lot of associated features, but those are the three features: small eyes, the smooth philtrum, and the thin upper lip. Alcohol is what's called a teratogen. A teratogen is a substance that when you put it in contact with a cell, it will kill that cell. So for example, if I take a brain cell, a neuron, stick it in a petri dish, it can still live. You give it the right nutrients, it's doing fine. You stick alcohol in it, it will kill that cell. There's a lot of other substances that may affect that cell. Cocaine affects that cell, but it doesn't kill it. Technically, cocaine is not considered a teratogenic drug. The other thing that is important to know about alcohol is that it passes freely through the placenta. There is no filter for it. Within a couple of minutes of mom drinking, the fetus has the same blood alcohol level, and think about it, it's a much smaller system, so it has a larger proportion that way. Early on in pregnancy, the fetus, the embryo, does not have a functioning liver. It can't process alcohol itself. It's dependent on mom to process out the alcohol. And we know that alcohol causes damage from a very early time in pregnancy. And it can happen very soon after alcohol comes on board. So there have been, I should not say we, there have been animal studies. This is a mouse. This is a mouse that was exposed to alcohol, and 12 hours later they sacrificed that fetus and looked at its brain. They stained the brain, or the body of the mouse fetus, with a substance that picks up on dead cells. That's what those black dots are. There are a lot of black dots. Those black dots are centered right at the very front of this developing mouse. That's where the brain is going to be when it develops. So we know alcohol very much targets the brain in individuals when they're exposed. So alcohol does have a lot of different effects. One, it'll kill the cell directly. You get alcohol on board, it will kill that cell. As mom is processing alcohol through her liver, she's breaking it down, and the first metabolite, first broken down component of alcohol is what's called acetaldehyde. That is also a teratogen. So even though mom has now processed out the true alcohol, what is left over is still a teratogen. So it takes even longer. It's still being exposed longer. One of the other things that alcohol does is it can shrink up the blood vessels through the placenta. And so you get what's called a hypoxia, or lack of oxygen, or decreased oxygen. So you can get impairments in functioning later that are partially due to just the baby didn't get, or the fetus didn't get enough oxygen during that time. Within the brain itself, alcohol affects all the different stages of development. When the brain is first being developed, all the cells are kind of replicating themselves quite quickly. Alcohol can stop that process, so you're not getting all of the generation and proliferation of those cells that you need to have in order to have a normally developed individual. Typically, when parts of the brain is developing, they tend to develop kind of in a central place, and then they migrate out to where they need to be in the final form. And alcohol stops that migration. In fact, some of the first studies that were done of autopsies of babies that died right after birth, they found these lumps of gray matter, cell bodies, in places where they shouldn't be, in places where there really should be these white matter, these connecting pathways. Heterotopias is what they're called. They found those. So it stops that migration of those cells. When the brain is, or when the cells finally get to where they need to go, they need to actually be able to talk to each other. And so they send out little pathways to different parts of the brain. Alcohol can stop those pathways from developing. At the same time, when we are first developing all those pathways, we develop way too many. We have connections going from here to here, yes, we need that. But we don't need a connection from here to here. So there's a process of pruning, apoptosis, where that connection that isn't needed gets rooted out, it dies off. Alcohol can stop that process of pruning. So you have those connections that go from here to here, we want that, but from here to here, we don't want that. So this part of the brain that doesn't know what the heck what it's seeing, what it's hearing. And so confusion sets in. You have problems. And we see that in individuals with FASD all the time. They have a hard time processing what is going on. Alcohol does have different impacts depending on pregnancy, depending on when during pregnancy it can be. And there are different outcomes. You can have individuals that are they're incompatible with life. Alcohol caused so much damage that they are going to either be a spontaneous abortion or soon after birth, a failure to thrive, or early infant death. The malformations, the physical malformations that we talked about as far as the facial features, growth deficiencies, like I said, people with full FAS do tend to be fairly small or very thin, although as they move into maturity and through puberty, oftentimes that goes away, they become more heavy and obese. Similar things with the facial features. As they go through puberty, they tend to become much more subtle. We don't see the philtrum as being readily apparent as we might have when they were a 3-year-old or a 4-year-old. They smooth out, or they tend to, there's change in musculature with hormonal increases, and so you may start seeing kind of this normalization of physical features. And then what I pay attention to, the functional deficits, how it impacts their day-to-day functioning, how it impacts their ability to learn, remember, solve problems. Early on in pregnancy, you do tend to see the physical features of FASD. Really, the facial features are kind of laid down in the first 6 to 8 weeks of pregnancy, very early, often before mom knows that she's pregnant. Later on in pregnancies, in the 2nd trimester, we tend to see a lot more spontaneous abortions, and in the 3rd trimester, when there's all this growth getting ready for delivery, we tend to see growth deficiencies occur. But any time in pregnancy, the brain is being developed all throughout. So alcohol at any point will affect how the brain is developing. So alcohol has that direct effect on how the brain develops, and that leads to the primary disabilities. The cognitive impairments that we see that were talked about as being the areas of challenge for people with FASD, troubles with learning, troubles with memory, sometimes intellectual functioning, and things like that. So we're looking at those primary sorts of disabilities. Some of these direct effects, this was a study that was done down in California. These are some children with, that were exposed to prenatal alcohol. I don't have the comparison slide, sorry. In the brain, in the normal brain, there is a piece of the brain called the corpus callosum. It's a white matter pathway. It connects the two sides of the brain. We really need that sucker. And it's usually a pretty thick, bright white, yeah, something kind of like that. This bright white sort of thing. And that's all those connections that go across the two sides of the head. These were 3 different children with FASD. This first one, that's their corpus callosum. This little bit here at the front. It should go all the way back to here. So they have a partial agenesis of the corpus callosum. The second one, that's actually the corpus callosum, that white thing right there. Very, very thin. And this is a child that actually had no corpus callosum, complete agenesis. That can occur. It's relatively rare, but it does occur, and white matter pathways do seem to be very prominent in most of the research that we found as being areas of impact. And that makes sense because there's a lot of processing, connectivity, and being able to coordinate that goes on when we're doing our normal day-to-day thinking. And that's an area where people with FASD do tend to have difficulties with making those sorts of connections. Again, this is a corpus callosum, but it's not even normal. You'll notice there's this kind of chunk out of it that's not supposed to be there. And this area back here, actually all the way across, is pretty thin. So this is a person who, if a radiologist were to look at this, they may just say, oh yeah, this is normal variation, it's normal. But when you actually measure it, it's significantly thin. And this person had significant cognitive impairments to go along with that issue. There are a number of different techniques of taking pictures of how the brain is, of structures of the brain. One of them is to look at kind of those pathways, and this is a type of imaging system or imaging method called diffusion tensor imaging, and it looks at those pathways across the corpus callosum. That's a very normal looking corpus callosum. It's got a lot of pathways going across, also has some that go up and down, but this is one that was an individual who was diagnosed with FAS, or FASDs, I should say. Not as many of these branches of pathways, much smaller. There's also sections that there are more, but sections that there are less. So this is definitely an individual with an FASD. Alcohol can affect any part of the brain. So this is a lovely dissected brain. The cerebral cortex, that's kind of where your primary thinking area goes on, where the gray cell bodies of the neurons are. You talked about the corpus callosum. There's also this area back here called the cerebellum. In the past, we've always thought that the cerebellum is kind of related to motor coordination, things like that, but now we know that it's really important for timing and being able to coordinate not just your physical body, but how you do tasks and how you can think through situations, and not only just physically. And also, interestingly, the olfactory bulb, smell. Smell is often impacted with individuals with FASD. We don't measure it very often, but they do smell things differently a lot of times. Hippocampus, I guess I'll focus on more. That is a part of the brain that's heavily involved in learning and memory, and we find that is smaller in individuals with FASD. But anywhere during pregnancy, alcohol comes on board, it can impact whatever system is being kind of worked on at that time. And so it can impact any part of the brain, but these are areas that we tend to see more frequently. So, okay, fine. This person has some sort of oddity in their brain. It's not normal, but maybe it doesn't affect them very much. So then we start looking at behavioral studies. One of the other things that I often get is, well, yeah, I mean, this person doesn't do well at such and such, but, can you really say that alcohol caused that? Well, we can do that because we can study animals. In animals, we can control everything, and we can control how much alcohol gets on board. We obviously can't do that in humans. That would be very, very bad, and I would lose my license, and I'd probably be in prison for a while, and all that sort of thing. But we can do it with animals. And this was a study that was done, I think in North Carolina, where you take these chicks. So this is a normal chick. Let's explain the environment, their test, and let's not go past that. What you've got here is this little room with a window and food on the other side. You drop a normal chick in. Obviously, they want food. So, they see the food, they run towards the food, they bonk their beak on the window, pick themselves up. See the food, run towards the food, bonk their beak on the window. They do this a number of times. Chicks are not the brightest. They learn eventually, and they kind of go, well, this is useless. Let's see what else we can do. They look around, they find a door, they go out, they get to their food, they're very happy. You grab that chick, throw it back in. Very quickly, it learns. You go out the door, go get your food, you're a happy camper. Take the chick away, a couple weeks later, you put it back in, very quickly relearns to go out the door and go get your food. You take the alcohol exposed chick, sees the food, runs towards the food, bonks his beak on the window. Picks itself up, sees the food, runs towards the food, bonks his beak on the window. Picks itself up, sees the food, runs towards the food, bonks his beak on the window. It has a really hard time learning from its mistakes. In professional neuropsyche terms, they are perseverating. They're doing the same thing over and over again, even though it's not effective. They may eventually find this door, go out, get their food. They're very happy. You throw it back in to the room, sees the food, runs towards the food, bonks his beak on the window. Even though it's gotten success, it still has a hard time learning. Eventually, that chick will learn, and it will be able to pretty consistently go out that door, go get the food. You take the chick away for a couple weeks, put it back in, it sees the food, it runs towards the food, it bonks its beak on the window. It doesn't remember what it learned. It has a hard time solving problems, and it has a hard time holding on to memory when it has finally solved the problem. We talked a little bit about intellectual functioning, that most people with FASD are not intellectually disabled. Absolutely true. It is the leading known cause of intellectual disability, FASD is. But only around 20% of people with FASDs have IQ scores that are essentially within the intellectually disabled range, an IQ of 70. Fairly rare. They are definitely lower than average population, but not by that much. This term FAE, fetal alcohol effects, that was an older term from the 70s through the 90s that basically was for people that may have had some of the physical features or none of the physical features, but did have the exposure and had significant impact. So these would be the partial FAS people or the ARND people. Their IQs are definitely a little bit lower, but still within the normal range. People with FASD or with FAS had IQs that were, again, a little bit lower still, but average of 79. So again, not within the intellectually disabled range. But there's a difference between what you know and what you can do independently on a day-to-day basis. What they know, IQ scores, broadly in the average to low average range. What they can do on a day-to-day basis, much, much more difficult. So this is a test called the Vineland Adaptive Behavior Scales. It's an assessment of, or it's a interview or questionnaire of people who know the person about how a person can do things, a person with FASD in our case, how they can do things independently without supports around them. If they had to do it on their own, how can they do these things? So here's the FAS group, average score about 79, but look, they're adaptive scores. They're communication, daily living, hygiene, taking care of the house, cleaning up around the house, or school or environment-based daily living, managing in school, managing jobs, things like that, and socialization, interactions, interpersonal, coping with change. All of those are significantly below their IQ. That's what this dotted line is. And you'll notice, on average, they're within the intellectually disabled range. So this person with FAS, IQ is not intellectually disabled, but they're functioning as if they are. Important. FAE, their IQ scores are in the normal range, a 90. And yet they have exactly the same pattern and level of adaptive functioning impairments. They're also functioning within the intellectually disabled range. But IQ, so their ability to apply the knowledge that they may have is they have significant difficulties with that. There are a lot of red flags that we can look at for possibly raising the concern about possible FASD and for seeking some sort of an assessment to see if the diagnosis would be appropriate. Now, having said that, there are also a lot of these red flags can apply to a lot of different conditions. So we do need to also at some point understand about prenatal exposure. In childhood, prematurity, very common for individuals with FASD. Seizure conditions, we see maybe about 20% of people with FASDs have had seizures. Not necessarily a seizure disorder, you know, epilepsy or something like that, but they've experienced seizures. So we talked about the kind of stress-induced seizures, very common with individuals with FASD. Motor delays, early developmental delays, things raising red flag. We talked about some language problems early in life. One of the big red flags that I look for in records is if they were involved in special education services. There are still kids with FASD who fall through the cracks and don't get picked up as being needing special ed, but it's at least more and more common that it occurs. Academic problems in school, behavior problems, especially kind of these instant reaction type behavior problems, something that we see very often. And when you ask them about it, they get suddenly angry and then it's done and it's almost like the light switch went off and they're no longer angry and they don't know, you know, it's why are you still making a deal out of this? It's gone, it's done. And then a lot of mental health diagnoses. You know, kind of one of the red flags that psychiatrists and psychologists do is if you're getting more than 4 or 5 mental health diagnoses in a kid, there's something else going on. It ain't just major depression and anxiety and, you know, et cetera, et cetera. There's something behind all of those things. Into adolescence, there's a lot of school failure issues. They drop out of school, they're suspended from school, they're expelled from school. Again, mental health problems become even more prominent. Onset of substance use. In some of the studies that have been done, we find that individuals that were exposed to alcohol prenatally are much more likely to develop problems with alcohol and substance use, and when they do, it's problems, not just experimentation, it's problems, and they start much earlier. We had done a study where by age 14, they were having troubles with blackouts and in troubles with the law because of their substance use. We heard about this already. Like I said, you already had the experts this morning. Troubles fitting in with peers, especially age equivalent peers. They may fit in better with adults, partially because the adults can kind of are a structure and support, sometimes for better or for worse. And they fit in better with younger kids because a lot of times that's sort of how their brain is working, is more on a lower age level. And these self-regulation problems, having a lot of difficulties with these impulsive decisions. So I talked a bit about these primary difficulties as far as the cognitive impairments. Then you have what are called secondary disabilities. These are not things that you're born with, but these are things that come along with your cognitive problems. And so you then have troubles with schooling. Like I said, this study that was done was not, did they have difficulties in school, were they in special ed or things like that. This was disruptions. They were expelled, they were suspended, they left school early. Over 40% of people with FASD have had that in the study that we did. Troubles with the law, very common. That's a large part of my practice is doing criminal forensic work for people suspected of FASD. Confinement is either in a psychiatric, mental health, substance use, or in judicial systems. Pretty common, over 30%. Inappropriate sexual behaviors, extremely common for individuals with FASD. And this isn't necessarily the predatory type of behaviors that you usually might think of for inappropriate sexual behaviors. These could be, well, think about it this way. You have a child, 5 years old. They have no stranger danger, we heard that earlier. So they come up to a person They jump up into their lap and they hug them and they sit on their lap for a little bit. Okay? That's very cute. We all love that. It's terrific. They do that when they're 9 or 10. It's like, okay, you're getting a little heavy, kid. They do that when they're 13 or 14. It's like, this is a little bit odd. And they do that when they're 18 and they get thrown in jail. It is the same behavior. It's just society that's treating it as a different behavior now and punishing it. So that's what a lot of these inappropriate sexual behaviors are. They're advanced, asking somebody out when it's totally inappropriate to do so. They can be actual predatory behaviors, but oftentimes it's not in a predatory mentality. It's impulsively, they want to have sex with somebody. And they do, and unfortunately, gets them into trouble. Alcohol and drug problems, I've seen kind of this dichotomy. Like I said, people with FASD are sensitive to, and some of the research is showing that they tend to have greater problems with alcohol or substance use, especially early in pregnancy. But there's also on the other side of the coin of individuals who are very, very adamant and very good about abstinence. Because my mom had troubles, and she drank while she was pregnant. I don't blame her for that. That's not going to happen to me. I will not drink. I will not use drugs. And they're very, very diligent about that. And so there's this dichotomy. It's really a dual curve. And then dependent living. Can they live on their own and manage finances and things like that? Very few do. They also have very significant problems with employment. In fact, out of that study that we did back in the mid-90s, only 7 out of 90 adults could live independently without major problems with work. Very common issue. So support services for adults through SSI, through other financial supports, as well as vocational supports, vocational rehabilitation, things like that are really important. I talk a lot about the brain because that's kind of what I'm interested in as a neuropsychologist. But it's important to recognize that there are a lot of other systems in the body, and they can all be affected by alcohol. Skeletal problems, autoimmune problems, kidney, liver difficulties, sleep disorders that we talked about, which does border into our area, and hearing problems and vision problems. There's one researcher in Europe who focuses entirely on the eyeball and the back of the eyeball and what the retina and the blood vessels in the back of the eyeball are. And she's worked out ways of actually helping with the diagnosis based on the tortuosity of those vessels in the back of the eye. So there's a lot of other systems, and it's a whole body diagnosis. And we're also concerned about later in life. Is there early deterioration? Do we see early dementias? We don't know for sure yet, but there's kind of concerns about that. And myself and Dr. Ann Streiskooth, who was my supervisor mentor at the University of Washington, we were concerned about that, and we were talking about that in the 90s, but we just didn't have, we were seeing younger adults most of the time. Other screening materials. This is in your handout. It's from Dr. Larry Bird. It is an incredibly good screening tool that anybody can use. It screens both for the physical side of things, the physical features, and it screens for behaviors, kind of this behavioral checklist. Again, keep in mind when it comes to the behaviors, if you get a few of these, if your child or the adult gets a few of these, it doesn't necessarily mean that they have FASD, because it can be caused by a lot of other things. But as you get more and more, it certainly raises the red flag that you need to pursue this assessment. I'll let you guys look through this in larger detail because you can't see that very well, but it is in the handout. I recommend that you look through it. It also talks a little bit about how you ask about alcohol exposure, because that's an important part of the FASD diagnosis, is to know about the exposure. This is another screening tool that is that's used in a forensic setting, because there are behaviors that people do in criminal cases that are really consistently seen with people with FASD. These impulsive decisions. We talked a little bit more earlier about cause and effect. People with FASD can, after the fact, tell you that cause and effect, but they can't see it in the moment. They see something, they want something, they get something. That impulsive behavior. Or they may do some reasonably elaborate criminal activity, but they didn't plan about how they're going to get out of the house after they got in. And so they get nailed because there they are. Or they're part of a crew, and the leader of the crew says, hang on to this bag for me, we'll be back in 10 minutes. They off-ski because they know the cops are coming, and our child or our adult with FASD is holding the bag. Also, individuals with FASD are oftentimes very suggestible. Under questioning, they may admit to a lot of things that never happened, that they didn't do, or over-express what did occur, so actually they get upcharged because of that. We've had cases where, you know, an individual goes into an interrogation and admits to an arson. When you come back to it, you know, 5 years later after they've been in prison, you realize they weren't even in the state when it happened. So these sorts of things that we see where they're not the leader usually, they're the follower. Those are some screening ideas that you can get in a legal area that should prompt you to start looking at getting an assessment for FASD and possible diagnosis. Let's introduce you to Jane. So when Joanne was working with me with those PCAP moms, this was Jane. She came in, 24-year-old, right-handed, Caucasian, single mom. Their child was, she had full custody. Right? She had custody. They were working, PCAP was working with them on that. She was not working because she was in an intensive drug program. And they wanted to know, did she have an FASD and what her neuropsychological profile was. It should be noted that we never were able to confirm if Jane was exposed to alcohol. We could not get that documentation of it. So I'm going to let Joanne kind of explain a little bit more about Jane.
So thanks, Paul. Is everybody able to hear me? I tend to talk quietly. So I had the pleasure of working with Jane. I did a neuropsych eval with her, and when we first got together just to chat, I wanted to get some background information from her. She shared with me that she was anxious to start her life. She really wanted to develop an understanding of what was going on in her head. She told me that she felt like something was wrong, that something was preventing her from not being able to be like others. And she became really tearful as she talked about things like school failure, but her desire to go back to school to get her GED. She wanted to find gainful employment. She wanted to be successful so that she could support herself and her children. And she wanted to accomplish things in life because she wanted her children to be proud of her. And this is another thing. Jane had two previous children that had been removed by Child Protective Services because she was not able to maintain their care and follow through some things that were required. And I just want to put in a quick plug. As you're hearing Paul and I talk about these things throughout our presentation, be thinking about the case study that we're going to be looking at this afternoon. Think about the red flags, think about the cognitive issues, think about maybe some of the social issues swirling around the individual, so that we can get into group discussion this afternoon. So, closer? Yeah. Thanks, Sean. Okay. All right. So when I asked Jane to become a bit more specific about her cognitive complaints, she shared a lot of things that are just sort of flag for us when we're doing evaluations. Problems with attention, concentration, learning, memory. She had problems with expressive and receptive language, and she shared that these problems had been of long standing. Jane found herself becoming distracted by visual stimuli, auditory stimuli. She struggled with new learning. She didn't have a memory for numbers, couldn't follow directions, or if she was driving, oftentimes got lost. She had problems understanding what people said to her, especially when what was being shared was highly complex and required her to sustain her attention and could really follow along and maybe even sort of fill in the blanks, think abstractly, pick up on nuance, implicit meaning. She had problems with expressive language and would often talk around things to try to make her point, and this often frustrated people because they would just sort of look at her and go, "I still don't know what you're getting at." Jane also shared she became overwhelmed when presented with too much information, and she just struggled to find a way to organize things for herself. So she functioned best when things were presented in a very straightforward kind of way, and when things were written down for her. It sounds like she was maybe more of a visual learner, right? And she also shared that she struggled with emotional processing. Emotions felt big. They went from 0 to 60 at times, and sort of self-regulation could be a bit of a challenge for her. But she was more of an internalizer as opposed to an externalizer, where she demonstrated her challenges through becoming really anxious about things. Education-wise, struggled a lot in school from the time she hit 3rd grade, and that tends to be a flag for a lot of us. And think about what happens when you're in 3rd grade and how structure goes away and how pictures stop showing up in books, and you have to start organizing some things on your own, and it starts to fall apart if you don't have the supervision, right? Jane also ran into issues with being bullied in the classroom, and that was really hard to hear, and how that impacted her self-esteem and also her anxiety and depression. And then finally, she ended up leaving school in 6th grade to be homeschooled because teachers didn't know what to do with her, parents didn't know what to do with her, Jane didn't know what to do with her, even with an IEP in place. So we'll be coming back to Jane shortly.
So, and then focusing on kind of neuropsychological assessment for FASD. There are a lot of different systems that are out there, unfortunately. It can get kind of confusing. There's the Institute of Medicine system. There's University of Washington has their own diagnostic system. There's a lot of different systems. They have different criteria, different some of them more specific types of criteria, some of them less specific, some of them more restrictive. So the type of, the criteria that I tend to use, I'm looking for deficits at least one standard deviation below the mean. So you've got an average score, and then you got a range around it, the standard deviation. And if you have a score that is less than one standard deviation below the mean, that means that 86 out of 100 people do better than you on this test, this score. So I'm looking for that level. That would be a mild impairment. But I need it in more than just one place. I'm looking for deficits in multiple domains, at least 3 different domains. Some other systems require deficits that are at least 2 standard deviations below the mean. That means that 98 people out of 100 have to do better than you in order to qualify under that. Much more restrictive. When you have that happen, it's very telling. It's within the moderately impaired range. What I like to do is I like to be able to catch people who are even on the mild end. So that's why I use that diagnostic scheme. But there are a lot of others. And then, like I said, some are more structured than others. The DSM-5 is saying they have deficits in these areas. Well, what's a deficit? That can be different for different people. So if you can set a very structured diagnosis, that really helps. What we expect to see for people with FASD when I'm doing an assessment. Because alcohol is non-specific, it can affect a lot of different parts of the brain depending on when it comes on board and depending on how much is used, depending on the genetics of mom, genetics of the baby, metabolism. All these things do affect, so it's non-specific. I guess I said that. So I'm not looking for specific areas that have to be there every single time, because we're not going to find that usually. We've wanted for years to find the profile of people with FASD, and I honestly don't think that we'll find it because of that variability in all these other areas of timing, dosage, and just genetics and metabolism. Again, we already saw, we do not expect to see a person with an IQ that's in the intellectually disabled range, an IQ of 70 or below. It's not that common. But we do tend to see splits across domains. So when you do an IQ test, it's looking at verbal scores, it's looking at nonverbal sorts of things, it's looking at kind of working memory, being able to keep information in your head at once or work out problems, or it's looking at processing speed. People with FASD may not have IQs that are within the intellectually disabled range, but they often have big differences across those different domains. So we often will see those splits, and that's more telling than a score, an IQ score. We tend to see this patchiness for people with FASD. They do well in some areas, they do poorly in other areas. Again, it makes sense based on timing, dosage, all other considerations. As opposed to somebody who, let's say, does have an intellectual disability, where you tend to see almost all the scores tend to be low. Or somebody who has a more focal condition like a head injury, that can be more broad because of the way that mechanics of a head injury works, but you often tend to see more focal deficits in one or two areas rather than across the board. Especially strokes are like that, where you just see these focal deficits. Academic impairments are very, very common. Academic difficulties in school, special ed, and their performance on testing, especially math. Once you get past 1 + 1 = 2, it's a pretty abstract concept, math is, and people with FASD have a lot of difficulties with that level of abstraction. So oftentimes math is the worst, not always. We do have our individuals with FASD who just kick butt in math. They have other academic difficulties then. This is one of the hallmark ones that we do see very commonly, are visual spatial construction impairments. People with FASD are often very creative, very artistic. You put a paper down there and they draw something and it can be gorgeous. You put a complex figure in front of them and say, copy that, they have a lot of troubles doing it. They have troubles organizing their thoughts, how they're going to approach it. They have troubles connecting information, and so they have a lot of difficulties with this visual spatial construction. It's something that we see very commonly with FASD. ADHD is probably the leading diagnosis that's made of kids when they eventually do get a diagnosis of FASD, so it's their first diagnosis that they may get. Attention problems are extremely common, and distractibility and impulsivity are things that we see extremely commonly with individuals with FASD. And then the social and adaptive difficulties. They have a hard time. They love being social. They want that connectivity, but it's sometimes inappropriate connectivity. And then they have what are called executive function deficits. So executive functioning is a complex group of skills. It's not one thing. It is basically planning, future-oriented, being able to get to goals, and that also means putting off kind of gratification, being able to withhold that gratification until you can accomplish that goal. An executive functioning task is, I want to buy a motorcycle. Cool. You got to save money for it. So you actually have to consciously work at saving that money and not go, ooh, look at that pretty XYZ, and they spend the money on that instead. They have to delay their gratification. So executive functioning is a very common difficulty with individuals with FASD, and it's especially as their need for problem solving becomes the skills that they need to demonstrate are less structured, there's less support for them, they have to work things out more on their own, they have greater troubles. If you kind of give them all the rules, they know exactly what they have to do, they just have to accomplish. They oftentimes can do pretty good at some of these problem solving tasks. It's when they have to figure it out on their own that they have more troubles. And like I said, people with FASD can be very highly suggestible. They're easily led, often the follower, and will succumb to pressure pretty easily.
can you say something about confabulation?
Yes. So there was a question about confabulation earlier. Confabulation is telling untruths, falsehoods. People may say, oh, that's lying. Individuals with FASD, individuals with neurodevelopmental disorders and other neurocognitive disorders, it's not really lying because they may actually believe what they're saying. This is my reality, and they may say these things. They may add information to fill in blanks because memory tends to be challenging for them. So they're confabulating on this information. It is something that is interpreted by others as being a very negative behavior, but it is, in some ways, it's them trying to, individuals with FASD trying to compensate for the weaknesses that they also experience themselves, or that they genuinely think that that is what happened, and that is their reality. The other thing that we do see with individuals with FASD is this a lot of variability, not just between different tests, but over time. A lot of parents with FASD talk about how, you know, we taught Johnny, we worked hard with him, he got it, he was doing great with it, and then like the next day it's gone. It's almost like it never happened and you have to retrain. But then maybe a couple weeks later, it's back again and they can do it. So there's this variability over time that we do see very commonly with FASD. And when we're looking at the neuropsych testing over time, we can see that popping up quite frequently. I'm not going to spend too much time on my battery. There is a handout that you've got that is actually a book chapter that I recently wrote, which is the battery that I use, the recommended battery that I use in legal forensic criminal cases. It goes into a lot of detail about that. It is a more in-depth assessment than you might be doing in a clinical situation. We'll talk about Jane versus a forensic case. But it'll give you all that, all the kind of the details, the nitty-gritty. The big deal for an FASD evaluation is you need to look at a lot of different areas. You can't just look at their IQ, their academics, and, you know, cool, we're done. No, you have to look at IQ, academics, their learning, their memory, maybe in different modalities, language-based versus visual, the visual spatial construction sorts of things. You need to look at that. You need to look at attention, motor coordination. Oftentimes the attorneys, when I say that, yeah, I'm going to do some motor tests, are going, why? Who cares? You know, unless it's how many times you can pull a trigger, we don't care about that. But in a third of the cases of individuals with FASD in the research that I was involved in, a third of them had motor coordination problems. So it's an important diagnostic factor. So we try and do that. We look at executive functionings, that planning, that problem solving, idea generation, a number of different tests, because like I said, it's not one thing, it's a lot of things for executive function. You need to look at a lot of different areas of that. And one is not necessarily more important than the other. They're all important to see where that area of weakness is. Then we also want to look at that adaptive skills. And sometimes it's not just, I shouldn't say just, it's not only a parent or a family member or a teacher information that we want to know about, how they do in the real life on their own without support. That's extremely important, but it's also important to kind of see how they can do on these more structured tasks, because we oftentimes will see kind of this decrement where they're doing pretty good when they're doing it in the classroom. They have a harder time when they're doing it on my testing, and then they really fall apart and have a lot of troubles when they're doing it independently. So I do a lot of things like receptive communication, asking them to follow instructions, or social interpretation, looking at pictures of people. How's this person feeling? Or hearing people talk, how is that person feeling? So being able to interpret social cues that can often become problematic. So this was that book chapter that I was talking about. Like I said, it's included in your handouts. And then this was what I tend to do, what I like, because what you can do as a neuropsychologist is you come up with a bucket load of numbers. And they're really helpful for me. I can use those and I can understand kind of what is going on and the interaction between that, because I've been trained and spent 30-odd years now in the neuropsych field. But it's sometimes kind of hard for others to kind of understand those numbers. So what I often will do is I will do a visual display. Once you understand the display, it makes it easier to kind of see that pattern. But let me explain. One of the things about the neuropsych testing is that we have a lot of different scores. We've got IQ scores that has a mean of 100 or an average of 100. We have what are called T scores that has an average of 50. We have scaled scores that has an average of 10. We got a lot of different scores, and it's hard to compare across. You got to really know what the heck you're doing, and have a lot of experience and a lot of training in it. So I make everything the same. I convert everything to the exact same scale, and that's totally valid to do. It doesn't change the significance of the scores or anything. It just puts everything on the same playing field. So we can compare them, not necessarily apples to apples, but Macintosh to Fuji apples. So we can compare them much better across. Another thing about neuropsych testing and psych testing is that sometimes a high score is good, sometimes a high score is bad. You have to know which one is which. I take everything and I convert it. If it's, and I convert it so that a high score is always good and a low score is always poor performance. So you can now look across. The green line on here is an average score. All else being equal, if everybody was perfectly normal, they'd kind of hover right around that green line. The red line is the cutoff for impairment. This is the old-fashioned, it's not really used as much anymore, the old-fashioned cutoff for intellectual disability. IQ is 70. And then this is that cutoff for that mild levels of impairment. All these dots, that's the scores that this person had on this battery test that I gave. And so you may not be able to read the actual test items, but they're broken up by different domains. I usually assess about 11 domains of function. And then we can look to see where this person's having troubles. And it's also important to know where they're having good abilities, where they have good abilities. So with this individual, here's their IQ. This is their full scale IQ. It's within the normal range. That's that dotted line. It's a normal IQ. But their nonverbal IQ was pretty good. Their processing speed was very poor. A lot of difference, very big, significant split. And when you have a score like an IQ, it's kind of an average. You're averaging all those other scores. And when you have big differences, that average doesn't give you as much information as it used to. So it's important to look at, in those cases, it's important to look at these individual scores. So that, again, like I said, that variability across domains, red flag. Academics. This person had troubles with both reading comprehension, but also math. Their kind of core reading and spelling was fine, but they had these impairments. So that's another domain of impairment. They had troubles with learning and memory, not in concrete, structured list sorts of things. They could learn and remember that really well, but when it became more abstract and complex, remember a story, that requires you to actually reconstruct information in order to be able to hold on to it and recreate it, to say it back. They had a lot more troubles with that. There's that visual spatial impairment that I was talking about. Popped up again. Interestingly, this person did great with attention. They did not have troubles paying attention. But they had a little bit of troubles with processing speed. Yeah, motor, some challenges. Here are those executive functions. They had difficulties in some areas, did really well in other areas. Variability across tests. This is the test of suggestibility that I give, and they were very suggestive. Here are some of those direct measures. This is comprehension, being able to follow instructions. This is being able to interpret social cues. He was doing fine, but when you look at those same things, interviewing caretakers, he wasn't doing well in the regular world. So he could know what the challenges were. He knew what a person was feeling by looking at their face, but he really had a hard time actually applying that in real life. So this is a very common pattern that we see. He had multiple domains. We did find confirmation of alcohol exposure, and this person was diagnosed, I think, with a partial FAS. They had some of the physical features. Let's go back to Jane. So Jane we saw as a clinical case. So we didn't go into as much detail on the quantity of tests. That battery that I do usually in a criminal case is 7, 8 hours. It's a long day. We're tired by the end of that day. In the clinical cases, we are still looking for multiple domains. It's really important to find those, but we don't give quite as many tests for that. But again, here's Jane's IQ. On average, she actually did have IQ that was in the mildly intellectually disabled range, but at the same time, she had really big splits across domain of IQ. Academic problems, look at that, there's math. Memory problems, she was okay at this structured learning of information, but had troubles retaining the information, and then when she was asked to do visual information, she had lots of difficulties, along with visual spatial construction difficulties. Again, in her case, attention not so bad. She did have more motor difficulties, and her executive function areas were definitely area of impairment for her. So Jane, in the end, we diagnosed her with learning disorder, multiple areas, and a cognitive disorder NOS. Now, cognitive disorder NOS, that was a diagnosis that we used to have in the DSM-4. We wouldn't call it quite that anymore, but we didn't end up diagnosing her with an FASD because we couldn't get confirmation of alcohol exposure. But regardless of that, it's a situation of it's walking like a duck, it's quacking like a duck, it's pooping like a duck. Maybe it's a duck. We might not be able to say it officially that it is an NDPAE. Oftentimes in these cases, I will say specified neurodevelopmental disorder, strongly suspected prenatal alcohol exposure. That puts it on the radar of, you need to work with these people in a different way. And so then you can work with them to treat them and adapt therapeutic interventions to better work with individuals that have the FASD. In Jane's case, the diagnosis with the cognitive disorder NOS, we were knowing that it was most likely an FASD, but we just weren't able to formally diagnose it. A lot of times people say to me, oh, doing an assessment or diagnosis of FASD it's just really, really hard, especially with adults. And my counter to that is the neuropsychological assessment for people with that, for consistency and patterns that are consistent with FASD is not hard. It's a normal neuropsychologist's day job. We're using very similar tests to what any other neuropsychologist uses. We have a structured criteria. You need to find deficits in multiple domains. You need to find deficits at least 1, or depending on your system, 2 standard deviations below the mean. It's not rocket science. It's not that hard. The challenges come in with the exposure, especially as individuals grow older. Getting that information will become much more difficult. There is, unfortunately, the stigma of admitting to alcohol use during pregnancy. It's horrible. I hate it because we're just trying to get help for this person. And it's not mom's fault that this happened. We just need to be able to understand so that we can work with them better. But also finding other sources, because maybe mom is not comfortable talking about it, and that's okay. But other people who are in their lives finding information about that is time consuming, it's challenging. In some of the cases, it was the bartender down the street remembers mom in there while she was pregnant, chugging away, having alcohol. So it can be other areas, but it takes a lot more effort to do that, especially as they're getting older. The other challenge is sometimes getting records, especially as they're adults. There are a lot of other things that can impact cognitive functioning. They could have had a head injury. They could be using actively substances themselves. Those all come into play. So getting those records from early in life can sometimes be more challenging, like the school records, to be able to document that, yes, there were troubles going on before the head injury occurred. Because then we know that, yes, likely there's the fetal alcohol spectrum disorder, but there may be this additional impact from the injuries, the head injuries that they have experienced. So that's where the challenge is. It's not in being able to do the assessment and being able to say, yes, this person is functioning as if, or like a person with an FASD. That's not the hard part. And I really want a lot of neuropsychologists to do this because I don't have the capacity myself to do that. I'll hand it over to Joanne for